Thanks again, Dr. Scott Regenbogen, for talking to OnSurge today about colostomies. We're aiming for sort of a chief resident level discussion. Tell me about location of colostomies.
So yeah, we've put a lot of emphasis on making good stomas. I think as colorectal surgeons, we see a lot of bad stomas, and we definitely see the difference that the quality of a stoma has on a patient's quality of life thereafter. So the first decision we always have to make is what piece of intestine to use as our stoma. And in general, we would say that the advantage of colostomies over ileostomies is lower output, less dehydration, a little easier to manage. The downside to a colostomy is that stool smells more than succus. So what I have to balance is amount of output against what the actual output smells like and is for the patient. So if I think someone needs a permanent stoma, I'll try hard to make it as distal as possible. In other words, a colostomy rather than an ileostomy. If I think someone's going to have a temporary stoma that I'm going to want to close, then I start thinking about what's the easiest stoma to close so that my second operation is safe. And for me, that's a loop ileostomy. So step one is, what's the right stoma for the patient? I think an ascending colostomy is probably the worst of both worlds, and I try to avoid that because then it smells and they have high output. Then I think about whether I'm likely to close it. So for example, if it is a diverting stoma above a low anastomosis, for example, in a patient with rectal cancer who received preoperative radiation, I'll almost always make a loop ileostomy so that the second operation is easy. If I'm treating, for example, someone with a, let's say, rectoprostatic fistula, where we're going to do a complex repair of a fistula, my first question to myself and the urologist I'm working with is, how likely are we to fix this fistula? If the answer is we're pretty likely to fix it, and the stoma is going to be temporary, I'll make a loop ileostomy. If the answer is we're never going to get this fixed, really, we're just trying to palliate, then I'll tend to make a colostomy. Second question is end or loop. So the reasons for making a loop stoma are one of two situations, maybe three situations. Situation number one is I'm planning to close the stoma, and a loop makes it easier to close because both ends that I need are up at the skin. Situation number two is there's a distal obstruction. So for example, an obstructing rectal cancer or a strictured anastomosis. And in that case, you want a loop stoma so that the distal segment doesn't blow out due to distal obstruction. And the third scenario would be where there's no actual obstruction, but I'm worried about the ability of that distal segment to close. So for example, a total colectomy for fulminant ulcerative colitis. I have to really evaluate that rectal stump and ask whether it's going to be adequate and safe. And there you might end up making some sort of a loop-like stoma where you bring the distal segment up. If I have a divided end or an open end on the distal side, sometimes I'll bring it up just as a little tiny opening. So you may just have that distal segment almost completely divided, but just a little bit of an opening to allow it to empty and deal with obstruction. Because in general, loop stomas tend to be bulkier and tend to be harder to really evert well. So that's decision making. What kind of stoma, end or loop, and under what circumstances? When we get to colostomies, really you're just trying to find a place that is easy to get the colon up to. So in general, patients will always appreciate it if their stomas are lower on the abdomen, and that works great for someone with a flat abdomen. For the obese patient, becoming increasingly common, you got to find something that does not reside on the downside of their abdominal girth. So it can't be facing the floor, or else they'll really have trouble with it. So the bigger the patient, the higher the stoma starts to get. As far as choosing a location, I think it's been well demonstrated that one of the best predictors of a good stoma is a preoperative marking by a skilled stoma therapist. So under almost every circumstance, I try to do that. If I'm here in the middle of the night and the stoma therapists are not, and I need to do an emergency operation, then I'll mark the patient myself, but I'll try really hard to stand them up. There are very, very few patients who you can't stand up before an operation, almost no matter how sick they are. If they're really sick, then I'll just try to sit them up. Because again, the position of someone's belly supine is going to be completely different, especially if they're obese.
Yeah, and what are you looking for when you stand them up?
Yeah, so when I'm marking a patient, the first thing I do is I mark their hip bone, their anterior superior spine, and I mark their inguinal crease. Then I mark their costal margin. I want to be far away from both of those. Then I look for any folds in the skin. There will often be one right at the level of the umbilicus, and I'll draw a straight line across any of those folds. Because again, I don't want my stoma appliance to be anywhere near there. Then I'll have in my hand the faceplate of a stoma appliance, so I can get a sense of how much space I need around my marked spot. Then I'll try to grab their rectus muscle if possible. Again, if they're obese, this may be hard, but try to get a feel of the contour of their rectus muscle and how wide it is. And then I look for a place, ideally not in line with the umbilicus, not in line with any of those creases, some spot that the patient can see when they turn and look down, and a spot that is parallel to the floor when they're standing up. And if I can find a spot that meets all of those criteria, that's my number one choice. If they're obese and they have a challenging abdomen, I may mark 2 or 3 spots so that I have a bunch of choices. But you'll find that the more obese, the higher you'll end up, and in a patient with a big belly, you're often above the umbilicus. Mm-hmm. For a sigmoid colostomy, I usually aim to be on the left side just because you're more likely to be able to get it to reach there. If I need to make an ileostomy, often on the right side, but there you have a lot of choices because the small bowel will usually reach wherever you want it to. I feel like a lot of my older, more experienced mentors made a lot of transverse loop colostomies as a way to get out of an emergency. And that's a stoma that I try to avoid if I can. Transverse loop colostomies, while they are a relatively straightforward, quick operation and a good way to get out of a really terrible situation, are really hard for patients to manage. They tend to prolapse a lot. They tend to be relatively loose output, and again, have kind of the worst of both worlds. So I will often aim for either an ileostomy or a sigmoid colostomy if I can do it safely.
Mm-hmm. So tell me a bit about mucus fistula. I've seen it done a couple of ways where I've seen it left sort of under the abdominal wall. That's not the case. But I've seen them put in the same position. I've seen them put it separate positions.
So mucus fistulas are often a damage control kind of problem. So in other words, you've got a distal obstruction or you have an excluded distal segment that you're really worried is going to break down and leak. So really, you got to take whatever it gives you. So if I take different scenarios, for example, someone who has fulminant ulcerative colitis, where I'm doing a total abdominal colectomy, making an endoleostomy, and leaving the rectum with plans for potential restorative proctectomy in the future. I have to ask myself, how likely is this rectal segment to blow out? So I try to leave it long enough that it can reach the abdominal wall, and then when I fire my stapler, I just try to make a good judgment about what I think the quality of the tissue is. If it seems okay, then I'll just leave the stump in the pelvis, recognizing that there may be a small risk of rectal stump blowout, which is a bad complication. If I'm more worried and my threshold doesn't have to be that high, then I will do exactly what you're describing. I'll take the rectal stump and sew it above the fascia but below the skin. So the way we'll do that is we'll pull the rectal stump up above the fascia. We will place some absorbable sutures from the anterior fascia to the serosa of the bowel itself or to the staple line to hold it above the fascia. And then we'll close the fascia beginning just above the stump in our usual fashion. The advantage of this is if the rectal stump blows out, they get a superficial wound infection, not a deep space abscess. The downside to this is that when we come back to do their restorative proctectomy, we have to reopen their midline and we can't just do it straight laparoscopically, but I don't consider that to be a major downside. If I'm really worried, like I really think that there's just no way this rectum's going to close, then I'll bring it all the way to the skin as a true mucus fistula. If you take another scenario where I'm only making a mucus fistula because of a distal obstruction, so for example, I can't just make a loop colostomy because there's some segment that needs to be resected. Let's imagine the patient has maybe a necrotic sigmoid colon and an obstructing distal rectal cancer or something, some terrible conglomeration of problems. I may resect the necrotic bowel, make an end stoma upstream, but I still got this distal segment that I need to do something with. In that scenario, you really only need a tiny blowhole, a true mucus fistula, just a place for mucus to drain. And I think at that point I would just bring that stump up wherever it can sit comfortably. If it can sit in the same aperture as the other stoma, even better, but often it can't. And I would really just open a tiny little corner of it. So make it a very small fistula so that a little mucus may drain, but the patient can probably just wear a Band-Aid over it. The only advantage of putting the two ends in the same aperture is if you consider this an opportunity where you're going to come back in the future and actually just put those two ends together, that would be a really good reason to put them in the same aperture. But otherwise, the advantage is pretty small.
Mm-hmm. What about Hartmann's pouches? Any tips on Hartmann's pouches?
So with a Hartmann's operation, you have, of course, two pieces. You have the end stoma and you got the distal segment. So my thoughts about the stoma, I would say, first of all, there are some people who have said, oh, you have to avert ileostomies, but you don't have to avert colostomies. And I've never totally understood that. I think that if you look at patients who have really good pouching of their stomas, having a nice everted, rose-budded, standing-up stoma really helps them, whether it's a colostomy or an ileostomy. So my advice on the colon side is make sure you preserve blood supply. really mobilize it well, especially in obese men who may have weighty mesentery. Really make sure that it's not going to retract. Get it well everted, get it well marked. Do whatever you need to do to get that spot marked before the operation, and try to make them a really nicely everted stoma, and really pay attention to blood supply, because a necrotic stoma is a real mess. On the distal side, on the rectal stump side, it becomes a question of assessing the integrity of the closure. So when we go back to do diverticulitis operations with anastomosis, we obsessively want to make a colorectal, not colocolonic anastomosis. However, at the time of the Hartmann operation, it's not essential to get down to the rectum. You can divide as long as it's below the perforation in any piece of healthy intestine, whether it's colon or rectum. So I just take the first healthy thing I can get to, put a stapler across it, try to get it to close. I'll often oversew that staple line, less for integrity and more so that other loops of bowel don't stick to the staple line as much. I do like this idea of putting a nice long Proline stitch that you can come back and find later, just in case it gets buried. So I'll usually take a Proline stitch as a little lembert and leave a nice long tail on it to find later. But I think the biggest and most important factor is just closing across healthy intestine. And if you can't find any, then bringing it up as a mucus fistula.
Great. Last thoughts, colostomies, ileostomies?
Well, I think as far as quality of life for patients, making stomas is, for me, one of the most important things I do. If I can make a patient a functional stoma, they can live a very high quality of life. If I make them a dysfunctional stoma, it really interferes with everything they want to do. So for me, it's really having good collaboration with stoma therapists, because they make a huge difference. Really involving them in the planning of the operation, counseling of the patients, teaching the patients, and then constructing a really good stoma. So a well-everted, well-vascularized stoma. The biggest issue I think we haven't solved yet in stoma surgery is hernias, and I don't have a good answer for that one. There's a real, what we might say Goldilocks problem of apertures being too small or too big, and very rarely just the right size, and I'm waiting for a good answer to that problem.
Do you ever put a prophylactic mesh in there?
I don't. So in my training, there was one of our faculty who was trying out the concept of a biologic piece of mesh placed in the within the rectus sheath as a prophylactic maneuver. I think the actual clinical trial data have been very mixed, and at the moment I've been reluctant to really add any foreign material, just for fear of making more problem than I can solve.
Sure. Well, thanks again, Dr. Regenbogen. Appreciate your input.
Thanks so much. I appreciate it.
Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook. Follow us on Twitter. And find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.